there is tissue hypoperfusion. So all those dependent portions have this ulcer. So it can be there in toes, it can be there on the buttock side, back side. Okay, so these are all stress ulcer. Anemia needs to be corrected. So what all needs to be monitored? Again, GCS needs to be monitored. Glaucoma scale needs to be monitored, whether it is improving or not. Mental status is improving or not. Respiratory rate needs to be monitored, whether respiratory rate is increasing or is it settling down. Saturation, whether it is improving or not. Heart rate, blood pressure, temperature, urine output. And on blood test, all those. So in the blood test, all this CBC, ABG, coagulation profile, and serum lactate needs to be monitored at frequent intervals. An indication of transfer to ICU is any of these organ system failure. So we have already discussed that whenever there is organ failure, single organ failure can be managed at HDU layer, but whenever there are either respiratory organ failure or two or more than two organ failure, patient needs to be managed in ICU. Now let us come to ARDS. So ARDS is most severe form of acute lung injury, and it is characterized by bilateral pulmonary infiltrate leading to severe hypoxemia in absence of cardiogenic pulmonary edema. This is very important. It should not be of cardiac origin. Cardiac condition leading to pulmonary edema is not ARDS. ARDS is occurring because of acute lung injury. And how do you diagnose this? So there is acute onset of respiratory symptom. It can be there in the cardiac pulmonary edema as well. Bilateral pulmonary infiltrates on chest X-ray. Again, this can be in cardiac condition as well. Absence of left atrial hypertension. Now, this is the one thing that is differentiating between cardiac condition and ARDS. PaO2, FiO2 less than 200. It can be there in both the conditions. So how do you manage this? So oxygenation is the most important thing, and treatment of underlying condition which is leading to ARDS. ARDS can be because of sepsis, can be because of pulmonary embolism, can be because of DIC. So this underlying condition needs to be treated to treat ARDS. In the meantime, you should ensure that oxygenation is maintained. Now, what is our aim whenever we are oxygenating? That PEEP requirement is less than 15, FiO2 requirement is less than 50, and PaO2 is maintained more than 60 mm of Hg. So in airway, low threshold for intubation in pregnancy should be there, because some amount of fetal hypoxia can be dangerous. Positive and expiratory pressure, PEEP should be maintained between 5 to 15. Fluid management, overload should be avoided. Restrict intake and judicious use of diuretics. ARDS not per se is an indication of emergency LSCs. Coming back to shock, so there are different type of shock. Hypovolemic or hemorrhagic shock, you all know. You all must have faced this many a time because of APH or PPH. PPH mostly occurring because of trauma, atony, retained products, laceration, and increta, creta, percreta, uterine inversion, all these things, and antepartum hemorrhage like placental abruption. So all this is hypovolemic or hemorrhagic shock. Then there is septic shock. So how do you differentiate all this type of shock? In septic shock, there will be warm skin, there will be flushed skin, which will not be there in the hypovolemic shock. It will be cold and clammy skin. In cardiogenic shock, there will be crepes present because of pulmonary edema. In anaphylactic shock, there will be pruritus and urticaria. There will be swelling in the skin. So through all these different points, you can differentiate what kind of shock it is. So how do you manage shock? Again, ABC is the first thing that needs to be managed, along with the left uterine displacement. Airway should be assured, breathing should be maintained, circulation, 2 wide bore cannulas. Restore circulatory volume and reverse hypotension with crystalloids. Cross match and arrange blood. C for response. So what do you do in cardiogenic shock? Yes, cardiogenic shock is a lot different than hypovolemic shock, because here you need to improve cardiac output and you need to decrease the preload on the heart. So how do you monitor this cardiogenic shock? So pulse, generally what will happen, tachycardia is there, volume is low, thready pulse, irregular pulse, blood pressure is low, respiratory rate is increased, cyanosis there, jugular venous pressure is raised. On CVS examination, there is presence of S3 click or absence of click. Respiratory examination, there will be basal creps present. So how do you manage this? Diuretics. So what will diuretics do? Preload will be decreased. What will vasopressors will do? Will improve systemic vascular resistance. What will inotropes do? It will improve cardiac output. So some of the dose of these drugs you should know always. You should keep in mind that what is the dose of this drug. Diuretics, how furosemide should be given. It is 20 mg, 40 mg, IV. How frequently you can repeat it. What needs to be monitored whenever you are giving Lasix or furosemide. So level of potassium needs to be monitored. Again, when morphine needs to be given, so again it reduces preload, it helps in pulmonary edema. What should be the dose? It is 2 to 4 milligram intravenously. Okay, so it can lead to respiratory depression as well. So along with that, it needs to be monitored. Nitroglycerin, whenever there is hypertensive emergency, it is not getting controlled on labetalol, nifedipine. Then dose of nitroglycerin, you should know how it should be started. Dopamine, dopamine, norepinephrine. So norepinephrine, all of you must have used one ampoule in 50 ml or two ampoule in 50 ml, but exact dose that needs to be started is 0.5 microgram per kg per minute. And how to titrate it, how frequently you can increase. So every 10 to 15 minutes you need to titrate the dose of norepinephrine. You should increase it accordingly. And norepinephrine is the first drug of choice for any of the resuscitation. It is not dopamine, it is not dobutamine. So this is very important. So let us come to anaphylactic shock. Again, this is very rare in developing countries. It is more common in developed countries because of food allergies and all. So there is acute onset of illness with involvement of skin or mucosa with at least one of the following. There is respiratory compromise, which is leading to dyspnea, stridor, wheeze, hypoxia. Reduced blood pressure because of systemic vasodilation, which is leading to syncope, hypotonia, and incontinence. Two or more occurring rapidly after exposure to likely allergen. So there is skin symptoms and signs. There is respiratory symptoms and signs. Reduced blood pressure is there. Persistent GI symptoms like pain, abdomen, vomiting, and this might be there. But we need to consider is that skin features are absent in 20% of patients. Hence, anaphylaxis is a differential for any acute onset respiratory distress, hypotension, and cardiac arrest. Now, let us come to this very important entity that we have so commonly nowadays, that pulmonary thromboembolism. So, incidence of pulmonary embolism is 1 in 1,000 to 1 in 3,000 deliveries, which is very high. So what are the signs and symptoms? There is sudden onset shortness of breath, chest pain, hemoptysis might be there, cough might be there. Signs, this signs is very important to identify or suspect pulmonary embolism. Tachypnea, tachycardia is there, elevated jugular venous pressure, which is not very common to appreciate. Loud P2, again, which is not very common to appreciate, but whenever there is acute shortness of breath, chest pain with tachypnea and tachycardia, you should suspect pulmonary embolism. Okay, and during pregnancy, risk factors also need to be assessed in individual patient. If there is previous history of thrombosis, thrombophilia, age is more than 35 years, BMI is more than 30, multiple gestation is there, preeclampsia history is there, patient is already a known smoker, varicose veins are there. If patient has undergone any operative intervention like LSCs, stillbirth is there, obstetric hemorrhage, postpartum infection. So all these are risk factors of pulmonary thromboembolism, and pregnancy in itself is a major risk factor for thromboembolism. So how do you diagnose pulmonary embolism, or how do you confirm? So first, on the basis of signs and symptoms, you identify the risk, and on the basis of this risk, you try to confirm whether it is pulmonary embolism or not. So for that, first of all, do bilateral lower limb Doppler. So this color Doppler will tell you whether there is deep vein thrombosis or not. If deep vein thrombosis is there, you need to immediately start anticoagulant, and this anticoagulant would be on therapeutic level, not prophylactic level. If DVT has been ruled out, but still you suspect that it is pulmonary embolism, the next thing that needs to be done is ECG. So on ECG, there is S1Q3T3. This pattern you will see on ECG. On chest X-ray, there will be pulmonary infiltrates. On ABG, you will be see that there is alteration in the oxygenation. So if this X-ray is normal, what else you can do if your suspicion is high? Ventilation perfusion scan. Okay. And if chest X-ray is already abnormal, then you can go for CT angiography. If pulmonary embolism is confirmed, therapeutic dose of anticoagulation needs to be started immediately. So what can be started for that? Low molecular weight heparin, enoxaparin that we already know, at the dose of 1 milligram per kg every 12 hours. So if a patient is 60 kg, 60 milligram twice a day needs to be started. If there is massive pulmonary embolism, better start IV unfractionated heparin. What is the loading dose of heparin? This is same for those patients with mitral valve replacement. That the loading dose is 80 units per kg, but in those cases already patient is on anticoagulant like one. In those cases we just switch it from one to other, so that's why we don't need to do this loading dose. In this condition we need to give loading dose, so 80 units per kg of loading followed by 18 unit per kg per hour of maintenance is required. And it needs to be individualized in which patient you need to give thrombolytic drug or embolectomy needs to be done. Okay. And maintenance, how long this maintenance dose of low molecular weight heparin or infractionated heparin needs to be continued? So therapeutic dose should be continuous at least 6 weeks postpartum or at least 3 months of treatment in total have been given. So minimum 3 months after such events needs to be given. What about fluid resuscitation? So intravascular volume most often is affected in critical illness. So prompt restoration of this needs to be done. And many of the randomized control trials have failed to demonstrate superiority of colloids or crystalloids for resuscitation or maintenance. So what are the indicators of tissue perfusion? One, level of consciousness. Second, vital signs like pulse rate, blood pressure. Second, acid-base status and serum lactate levels. Third is urine output. Fourth is urine output. So regarding resuscitation, there are crystalloids, colloids, and then there are blood products. In crystalloids, if we see, there are, yes, this side is missing. So there are different types of fluid, crystalloids, colloids. In crystalloids, you are already using NaCl, ringer lactate, and 5% dextrose. Plasma light is something new, but it is costly. That's why it is not readily available. But the difference that you can appreciate here is that ringer lactate and plasma light both have potassium. Plasma light have magnesium as well. So this needs to be considered whenever we are supplementing. Patient has hypokalemia, ringer lactate or plasma light is the drug of choice, is the fluid of choice. And second is colloids. So colloids most commonly available are 6% HETA stars, HES, which is already known as HES, 5% albumin, it is costly, dextran 40, 70, not that much readily available, but it has more osmolality. Now, whenever we are going for resuscitation, crystalloids are the first fluid of choice, and initial resuscitative fluid, it can be RL, it can be NL, it can be plasma light. And again, target is to maintain mean arterial pressure above 65 and urine output of more than 0.5 ml per kg per hour. Okay, so any of the side effect of crystalloid? Not much. Fluid overload can be there sometimes, but yes, colloids, they do have side effects, which is very important. So only recommended colloid for resuscitation is albumin. HES can lead to increased mortality and renal failure. Albumin 20% solution in isotonic saline is the preferred because it has less chances of any of the anaphylactic reaction or any organ failure. Now this is the maintenance dose after initial fluid correction. So maintenance is at the rate of 30 ml per kg per 24 hour. Again, it varies, depends on the surrounding environment, what sort of temperature you have maintained. Okay, so it depends on that also. So this is the rough fluid requirement in a day. You can say if patient is 65 to 75 kg, the per day requirement is 2100. This is maintenance requirement, and rate should be 85. So generally we keep our patient at the rate of 75 to 100 ml per hour after initial fluid correction. And this is the electrolyte requirement. So whenever patient is on fluid, sodium requirement is 1 milliequivalent per kg per 24 hours, which is already replaced by this NaCl or ring lactate. Potassium is very important. So 20 milliequivalent per 500 ml bag, it should be there. So if you are giving ring lactate, you don't need to add potassium to that. If you are giving plasmalide, it need not to be given. But whenever you are giving NS or DNS, potassium needs to be supplemented. Now let us talk about obstetric HDU and ICU. What's this medical ICU? What is the difference? So HDU ICU usually an obstetric department near the labor room or operation theatre. So there is prompt shifting of patient from either vice versa to OT to HDU ICU or HDU ICU to operation theatre. Beds may be converted into labor tables. An ICU is near to obstetric department. So this is very important. This is the fine difference that is there between obstetric HDU ICU and medical ICU. So what all setups is required for HDU and ICU? So the number of deliveries, if it is up to 250 in a month, then 4 beds required in HDU. If it is 250 to 500, at least 8 beds required. So for setup like GK, almost 8 bedded HDU is required. Okay, and all district hospitals should have HDU. All medical colleges should have both HDU and ICU. Every HDU should have one isolation room for patient who have either infection or any communicating disease or are positive patient. And every medical college should have 4 bedded obstetric ICU. So this is the setup. You can understand this setup very easily. That if you look at subcenter should have a woman who is skilled to attend deliveries. So skilled birth attendant should be there at subcenter. If we talk about PHC should have basic emergency obstetric care. CHC should have comprehensive emergency obstetric care. That means surgical facility should be available, blood transfusion facility should be available at the level of CHC. If we talk about district hospital, at least HDU should be there. If we talk about maternity and child healthcare hospital or like medical college, then it should have both HDU as well as ICU. So these are the conditions which require HDU admission. To just roughly summarize this condition, I would say whenever there is single organ failure or single condition which is getting deteriorated, then you manage those patients in HDU. Condition is it should not be respiratory failure. So whenever a patient is requiring CPAP or intubation or oxygen support, then in those conditions, just oxygen support by mask, you can manage it at HDU level. But whenever higher entity of respiratory support is required, patient needs to be shifted to ICU. Now, these are the differentiating pressure that whenever patient needs to be kept in HDU. So if heart rate is less than 60, more than 110, if respiratory rate is more than 25, if systolic blood pressure is less than 90, 160, if urine output is more than 30 ml per kg per hour, diastolic BP less than 50, more than 110, single organ dysfunction, then it needs to be managed in HDU. If this condition are getting worsened, like heart rate is less than 50, more than 140, respiratory rate less than 8 or more than 35, systolic BP less than 80, urine output less than 400 ml in a day, Glasgow Coma scale less than 8, multiple organ failure is there, or respiratory failure is there, need of inotrops is there, intubation is there, ARDS, DIC, and PS, if acidosis is very severe, less than 7.1, alkalosis is very severe, more than 7.7, if saturation is less than 90 on oxygen by mask, if sodium is outside 110, 160 milliequivalent per liter, can lead to cerebral edema. If potassium is in between 2 to 7 milliequivalent per liter. Either if it is less than 2 or if it is more than 7 milliequivalent per liter, so it can lead to cardiac arrhythmias. So again, this is general things that you need to take care of whenever you are shifting patients from HDU to ICU. All this history, examination, treatment, and all this should be properly maintained. Family should be informed why we are doing shifting from HDU to ICU. Obstetric HDU staff should be appropriately informed, and patient should always be escorted. Vital needs to be monitored while patient is being shifted. Oxygenation should be maintained. Airway needs to be ensured. Okay, so regarding location, again for obstetric HDU ICU, it should be near labor room and OT. Space for HDU 120 to 130 square feet per bed is required, and for ICU 130 to 150 square feet per bed is required. Manpower, again for 8-bedded HDU, 4 nurses, 2 emergency obstetrician on calls and medical officers should be there. For 4, again it is 2 and 1. So there should be a buffer zone before entry into HDU and ICU and waiting area. And this is again something you need to remember for exam purpose only, that what is required for HDU setup, ICU setup. Monitoring and management at HDU. You should always watch for any of this worsening of symptoms like pulmonary edema, ARDS, SIRS, multi-organ failure, poor cardiac output despite fluid resuscitation, septic shock, DIC. Okay, now fetal monitoring is again very important in these patients. So simple measures like avoidance of supine, hypotension by 15-degree left lateral tail is very important. Oxygen by face mask. Fetal condition should be assessed every 4 to 8 hourly. Corticosteroid coverage needs to be given if it is less than 34 weeks of pregnancy. Labor and delivery as per maternal indication if it is required. And mode of delivery is based on obstetric indication. So in any critically ill patient, time is very important. Your decision making should be prompt, and you should use or whatever help available at your disposal and call for help without any hesitation. Early warning sign, you need to recognize it properly and before patient gets deteriorated. CPR, high quality CPR with manual left uterine displacement is very important to prevent aortocaval compression. And then there is perimortem cesarean delivery. So if there is no return of spontaneous circulation within 4 minutes, it needs to be done. Within a minute, baby should be out, and it helps both mother as well as baby. In sepsis, initial 1 hour is very important. So as soon as possible, take samples, start broad spectrum antibiotics, which is covering both gram positive, negative as well as anaerobes. Initial resuscitative fluids, RL, it can be plasma light, it can be normal saline. But in any patient with shock, initially 2 liters of these fluid needs to be given as bolus. And then there is TN, TPN. It should be started whenever patient is on prolonged NBM state. If patient has been allowed orally, it is okay. But if patient is not getting nutrition properly, it should be started as soon as possible. All the district hospitals should have HDU and all medical colleges should have HDU and ICU. Early detection and appropriate intervention is very important in reducing mortality. Now this is very broad coverage how to manage a critical condition. There are certain conditions which you face commonly day to day, like DIC, eclampsia, and antepartum hemorrhage, which are the most common causes of mortality in setups like GK. So if you want to ask any question particularly,